Oh yeah, that would.
Okay, good, great, thank you. So this is one of these slides that I think Dr. Weiner was warning us about early in his talk. This is the problem with triple negative breast cancer is it's a much more aggressive cancer on average. And people with triple negative breast cancer don't do as well as people who don't have triple negative breast cancer in the long run. It's largely because our treatments aren't as good. We don't have as many treatments, but also the cancer itself is much more aggressive. And now I can't advance my slides. Fantastic.
Again.
So, moral of the story, there's animation. Moral of the story is that we really need better therapies, especially for this more aggressive subtype of cancer. So we talked about hormone-based therapies. There are HER2-based therapies, but in triple negative breast cancer, we can't use them. And what we've got is chemotherapy. And so chemotherapy is the backbone of the treatment for triple negative breast cancer. And there are a lot of them. There's a huge arsenal of chemotherapy, but as you probably know, chemotherapy has a lot of potential side effects. It can be pretty toxic. It can affect almost any part of the body, from the brain all the way down to the bones and the skin and the muscles, and anything in between. It's inconvenient. It requires, in most cases, IV treatments. People have to come in to clinic and infusion to get those treatments. That can be a problem for childcare, it can be a problem for transportation. And if you have to get repeated IV therapies, that can affect your blood vessels, which makes it very difficult to even give blood or get blood for blood tests. People can't work as much if you have to come in all the time for treatments. And that can lead to financial toxicity or financial problems and all kinds of effects on mental health have been described over time. And this is work that I've done now a while back, 2019, pre-COVID, like a whole different lifetime. But what we know is that more than half of patients report difficulties with non-physical concerns. So I think when you think about chemotherapy, you think about nausea and you think about all of the physical side effects, but there are all kinds of other things that this sort of treatment impacts. I'm just trying to make the case that we need better therapies. So you have likely heard of this concept of immunotherapy, which is the latest and greatest in all kinds of cancers. It's used in lung cancer and melanoma and bladder cancer and renal cell cancer. And it's kind of all over all the lay press in terms of cancer treatments. Well, what is it? Immunotherapy takes the brakes off the immune system. So immunotherapy, when there is an immune cell, and in this case, this is an immune T cell, the cancer cell comes along and kind of tells the T cells to stop working. It puts the brakes on the immune system. So the immune system's not fighting the cancer. But these immunotherapies, and here I've listed some here, we call them checkpoint inhibitors or immunotherapies or immuno-oncologics. They take the brakes off. So they allow the immune system to kind of get back in gear and fight the cancer and start attacking the cancer cells. So it's harnessing the own power of a patient's own immune system to help combat the cancer. And we now are using immunotherapy as part of the standard of care for treatment of patients that have triple negative breast cancer. And this is a slide from the initial presentation of a study called the Keynote 355 study. Keynote is a series of studies that studied Keytruda, very cleverly named, and there are like 1,000 of them. I only know a couple. I only need to know a couple, but there are a whole bunch of them. But this is Keynote 355. And what it showed was that when we add the drug Keytruda to chemotherapy, we actually, that combination prolongs the time that patients can stay on those treatments and prolongs the time to the cancer growing and having to switch therapies and furthermore, it actually prolongs how long people live. And in this case, it was in the the 355 study, it was a difference in overall survival of 7 months. And what when the people, the very smart people, not me, very smart people, did these studies, they found that the particular people who benefit were people who have certain levels of a protein called PD-L1. So immunotherapy is kind of the latest and greatest. Yes, please. Great question.
So people with higher levels of PD-L1 benefit
More.
People with lower levels of PD-L1 benefit a little bit?
The cutoff of this, it's a special test called the CPS, where the cutoff is 10. People who had a CPS of less than 10 did not seem to benefit, which is unfortunate, but I'll kind of direct you to our next talk after this, which is from Dr. Khan, who's going to be talking about phase 1 and early phase clinical trials. That doesn't mean that they may not benefit from some other combination of immunotherapy plus another drug or some other creative approach to kind of using the immune system to target triple negative breast cancer. And we've got trials that are looking at that, and I bet you're going to talk about it more.
Yes.
Hi.
Is that CPS 10 the same as blood tumor burden?
Oh, great question. Great question. It's not. So the CPS is looking specifically at PD-L1, which is when we think about the immune system interacting with cancer cells, there's an interaction between a protein called PD-L1 and PD-1. And when, so they're looking for a specific marker on the cancer. Tumor burden or circulating tumor DNA, is that, I think, kind of there's
one in the blood.
the one in the blood. There are a lot of different blood tests that we can do, but
Foundation.
But foundation is one thing, Signatera is another. Let's talk about both. So foundation is a blood test that looks at the DNA of the cancer and what are the mutations inside that DNA. What is making cancer cancer? So cells are normally controlled by your DNA, and under normal circumstances, normal DNA, it makes proteins and cells grow and stop growing in a regulated fashion. But when you've got abnormal DNA, there's a mutation. That's one of the things that can make cancer cancer. So you're looking for specific mutations in genes of the cancer cell itself. And why do we do that? Well, we actually have some drugs, not necessarily in too much in my talk today, but in other talks, and certainly in Dr. Khan's world, where when we see certain mutations, it may suggest that we have a drug that can target that mutation, which is one of the reasons why we check foundation. There's another test called Signatera, which is looking just at circulating tumor DNA to kind of give us a sense of how much cancer is around. Not usually used too much in this scenario. Other questions? Oh, yeah, great.
On a prior slide, you had
Sure.
a number of immunotherapies listed. Are those all using standard of care, or is it just the Keytruda?
In terms of standard of care for breast cancer,
Triple negative.
for triple negative breast cancer and breast cancer in general, but triple negative breast cancer, Keytruda is the only one that's approved right now. The drug Tecentriq or atezolizumab was approved a while back, but that FDA indication got pulled. The others are all FDA approved and are being studied. There have been studies that have been looking at nivolumab and ipilimumab, Opdivo and Yervoy. There are, we have a number of studies that look at durvalumab or Imfinzi. Who names these things?
I know.
Imfinzi. Sometimes it's harder than the brand name's harder than the generic.
There's a funny formula for how they come up with
It's-
names.
it's-
It's 3 or 4 syllables, and it can't sound like another drug.
That's right, and I think they get bonus points if they use Q's and Z's. So anyway, so it's just Keytruda that's used.
So what is to determine the PDL? Because I thought that was tumor burden.
Yeah.
PDL is not tumor burden. Tumor burden kind of speaks to the volume of cancer. And feel free, if you have a better way of explaining this, please chime in. PDL is measuring whether a protein is present on the tumor cells,
So-
not how much cancer there is.
What did you say the test was for that, CSP?
It's CPS, it's the CPS stand for
Combined.
combined
Prognostic.
prognostic score, something like that.
Okay.
It's a test that looks at how much is there and in what strength. It's a particular branded test that's associated with the Keytruda. They were kind of approved together.
I can try to do it maybe in a different language just to see.
Yeah.
So the
Portuguese,
CPS,
please.
the CPS or PD-L1 test, or PD-1 test. So those, the pathologist, which is the doctor that has a microscope, they get a piece of the tumor, they slice it, they get it into his face, he puts this dye, like PDL dye, and then he throws it. And then if it does have those receptors get in the dye, it catches it, and then when he looks into the microscope, he says, oh, I see everything is kind of lighting up for this PD-L1 receptor. That's a test that is easily done in the hospital. Like any pathologist can put it in the microscope, throw the dye in, and see it catches it. And that looks to see, do you have those markers that are gonna show that the immune cells are gonna engage with the cancer cells, and that's when Keytruda was more shown to work. That is the CPS combined positive score or the PD-L1 test, and that's all under just a microscope. Then we have the tumor mutation burden. Remember she was talking about how the tumor is made and this DNA code. So I think of that as like a barcode. You have a barcode at the grocery store, you read it, it tells you something. That's how we know the cancer cells has its like all like a bunch of random letters and codes that turns into some sort of message that can be read. If you have a lot of changes in the barcode, like the barcode is all like full of mistakes, that's what they call mutation burden. How many mutations do you have? Just one mutation or you have 30 mutations? And then that is something that they see when they read the whole DNA barcode of this cancer, which is the foundation test. That's a more expensive, fancier test. They need to look at the coding of all the cancer. And then they say, have a few mutations, your tumor mutation burden is gonna be low. If you have a ton of different mutations in the barcode is full of mistakes, then the tumor mutation burden is high. And that's another marker for immunotherapies to work. Immunotherapies like tumors that have a ton of mutations because they look angrier, and then the immune cells can recognize that better and kill. And the cutoff is interestingly and confusingly the same. So CPS of 10 and tumor mutation burden of 10. Both have two totally different 10s, but the number is the same. But if you have a TMB or tumor mutation burden higher than 10 mutations per megabase of the DNA reading, then you can get Keytruda regardless of your tumor type. If you have a CPS or PD-L1 ink test that is super inky, like super positive and colorful, more than 10, then you see they also can benefit from the Keytruda. So it's just different tests, but that same 10 makes things confusing.
Thank you for that clarification. Sorry, I'm gonna cut you off because we got more to do, but no, thank you for thank you for the clarification. There was a disconnect there, so you totally, I think, answered the question
Yes.
much better than I did. So thank you for being here. The really quickly, because we're down to 8 minutes, and I suspect that Renee is gonna come in and tell us that we have to stop, but lots of people with triple negative breast cancer, higher percentage than people without triple negative breast cancer, have a mutation in the genes BRCA1 or BRCA2. And those folks can develop, have a very high chance of developing breast cancer in their lifetime. And in triple negative breast cancer, it makes up about almost a quarter. BRCA leads to lots of errors in DNA replication. That's kind of how cancer is formed. And I'm not going to get too much into why, like how this happens. But people who have BRCA1 and BRCA2 mutations, cancers associated with those mutations are very sensitive to drugs called PARP inhibitors. So we use PARP inhibitors a lot in people with these types of mutations, and particularly in people with breast cancer, triple negative breast cancer. The pill, generally well tolerated, and is yet another drug that we can put in the arsenal against this cancer. And again, these are called Kaplan-Meier curves. If you've not seen these, basically it tells us what's happening with patients on the y-axis and how long out we go. And the longer, this tells us how many patients are alive in a big clinical trial and duration, so that you want the curves to be as flat as possible. So a curve that comes and that's a little much shallower is better than a curve that drops off. But this tells us these curves, these graphs are telling us that the drug olaparib in the top and the drug talazoparib in the bottom, both are very effective or more effective in people with BRCA mutations than not using these drugs. There's another really cool class of medications called antibody drug conjugates, which are, I kind of think of them like tumor-seeking missiles, because they're antibodies which are looking for a particular protein. They attach to a particular protein, but riding along with the antibody is a drug. And so when the antibody finds the tumor antigen that it's looking for, it delivers the chemotherapy drug right to that area. So it's a very exciting group of drugs. We've got a couple of them in breast cancer that we use very routinely. In fact, the first antibody drug conjugate in breast cancer was approved for people with triple negative breast cancer. This is a drug called sacituzumab, or Trodelvy is the other name. And it was based on a phase 3 large clinical trial of 530 patients, and found that people who received sacituzumab or Trodelvy did better than people who had just single agent regular chemotherapy that's really non-specific. So where are we moving? We've got to fine tune our treatments for metastatic triple negative breast cancer. So everybody with metastatic triple negative breast cancer gets genetic testing. What's the DNA that they are born with? We're looking for BRCA1 and BRCA2 mutations, as well as some other mutations that might suggest that people would respond to a PARP inhibitor. We're looking at PD-L1 status, which we've talked about. We look at HER2 status. So even though triple negative breast cancers by definition are HER2 negative, there is a class of HER2 low, which I'm not going to get into, but depending on if patients have a little bit of HER2 expression, they could benefit from this drug called Enhertu, which you may have heard about. We also look at mutational burden. We look at deficient mismatch repair, microsatellite instability. These are all markers of lots of mutations that suggest that those patients may benefit from drugs like Keytruda. And then more genomic and molecular profiling, like Foundation, to see if patients are eligible for, importantly, clinical trials, but there are a couple of other mutations that we look for that we have specific drugs. This is a really complicated slide that I probably can't explain, give it the explanation that it deserves. But this is a map of all of the different pathways that are used in some cancers, and it's not even all of them, it's just some of the pathways. And these red lines with the kind of stop sign, these are the drugs that we have that are either in development or approved already that may work against those particular proteins and pathways. These are all, cell growth is a series of light switches, and it's like a circuit, and you got to block the circuit in order to tell cancer cells to stop growing. So I know I told you that I didn't change any of the slides. This is Eleanor. She had her biopsy. It confirmed that she had metastatic breast cancer. We did check her PD-L1, and it did come back positive, greater than 10. And so she started on chemotherapy with Keytruda. And you can see that spot in the liver, that dark area of the liver, just the whole thing on the left side there. And her most recent scans show almost a complete resolution of metastatic lesions. So she's basically got no evidence of cancer on her scans. And then we dropped the chemotherapy. She's been hanging out on Keytruda. This is her most recent liver scan. Well, no, this was her most recent liver scan last year. So her scan this year looks exactly the same. But that cancer has completely resolved on the CAT scan. She's doing great. She has a man friend. She won't call him a boyfriend, because he's a man. And she retired from her job. She sees her friends. She goes to visit her family in Portland, multiple times a year, and they're going to the Caribbean. They go someplace fantastic every year with her man friend. So she's like living her best life. And it's just one of the success stories that I think she is really enjoying every day. She's been living with metastatic triple negative breast cancer now for over 3 years, doing fantastic. And I don't see that changing anytime in the near future. And hopefully if her cancer ever does make an appearance again, we'll have even more exciting options for her. It is 10:15 on the dot. I want extra credit. What, can I answer other questions? Anything else kind of come up in this? Yes, please.
Actually, for folks who have metastatic, does the Keytruda work better if it's in different parts of the body? You know, liver versus lung versus brain, bones, you know?
I am not aware of any data that suggests that it does work better in any particular part of the body. With the exception of it doesn't get to the brain all that well. And some of these drugs do penetrate what we call the blood-brain barrier better than others. And Keytruda is a big drug, it's a big antibody, so it doesn't penetrate as well. In my experience, people with bone-only disease and triple negative breast cancer don't tend to respond as well, but they also don't tend to be CPS positive. So it's, again, even triple negative breast cancer is a spectrum of diseases with not everybody's cancer behaving exactly the same way.
So if it's bone and then it's hard to do the test on bone biopsies,
Yes.
so you kind of have to keep repeating, you know, if it's just only bone and it spreads around.
Yes, and so bone-only cancer is challenging for a number of reasons. It's a little bit harder to follow on scans, and there are PET scans and bone scans and CAT scans, and they don't always follow the disease activity, for one. Second is biopsies are challenging because you've got to get to the bone and then it has to be decalcified, and sometimes you can lose some diagnostic material in that process. But oftentimes, because people with breast cancer do well for a long time, and the mutational profile can change over time, people can develop new things. We do biopsy sometimes people multiple times throughout the course of their treatment to see if there's something new that's developed over time, because cancers can develop resistance to things and create new mutations, and that all of a sudden we may have a new drug for. Yeah.
Is there a concern of number of scans that a patient should be, you know, subject to?
There's always kind of that concern about radiation exposure and, you know, are we scanning somebody too often or not often enough? And I think there's no standard answer to that question because every patient's different. And sometimes we do need to scan someone every 6 weeks or 2 months because we're really looking for a particular, we're watching them very closely. Other times we might do it less frequently. There's certainly financial considerations as well and convenience considerations. So there's no set answer to that. Typically, we do something every 3 months. Subject to change depending on a patient's particular situation. Thank you all so much for being here. I appreciate the questions. I'm sorry for the my lack of understanding earlier questions, but please don't hesitate to reach out if other things come up. Ask your doctor